Good afternoon, everybody. It really is a distinct honor and a pleasure for me to introduce our next speaker. He is someone who has taught me a lot about the fundamentals of brain death determination through his publications and through his work and through his collaborations. Eelco Wijdicks is a professor of neurology, College of Medicine at the Mayo Clinic. He's the chair of the Division of Critical Care Neurology and attending Neurosciences Intensive Care Unit at St. Mary's Hospital. And he's the founding editor of the journal Neurocritical Care, which is the official journal of the Neurocritical Care Society. For those of you who think you have thick CVs, he has single-authored 12 books on neurocritical care and edited or co-authored 7 additional books, all currently in print. He has over 750 research papers, topic reviews, and editorials to his credit. So I feel dwarfed, Dr. Wijdicks. He is, to me, the leading authority in the world on all things brain death, and it's a pleasure to introduce him and have him speak at this session. Thank you.
Thank you very much. That's a very kind introduction. So we're going to talk about an interesting topic and review its history and discuss some of its controversies, although there are not many if you would ask me. It all seems to me very clear-cut. So if you don't like the term brain death, you can say, well, maybe we should change it to total brain infarction or status de animatus, or my favorite, the aperceptive, areactive, atonic syndrome. So let's stick to brain death just to make it a little bit simpler when we get to our discussion. Everybody here would ask, where does brain death really come from? And how do we get to this situation? And I think that it may already been an observation in 1800 by a surgeon who said in his experiments that if you continue artificial respiration, it would be impossible to kill an animal by increased intracranial pressure. And that was an important observation because we all thought that cardiac arrest would be the first complication or terminal complication after an acute brain injury, but it is apnea. And that was an important observation because during that time and much later, when critical care started in the 50s, we were able to intubate patients and ventilate the patients. Some have argued to say this is the last rite before the end. Intubate patients with catastrophic neurologic injuries that otherwise would die, and we would not have the opportunity to maintain the rest of their organ systems. And when these patients were intubated and had a catastrophic neurologic injury, EEGs were done, and this is a landmark paper that looked at the EEGs in patients who became brain dead and found for the first time something that was not seen before, what we now know as a flat EEG. And this book shows clearly that there's an evolution of EEG, as you can see here, and they try to link it to some of the some parts of the neurologic examination. So the moment your EEG gets flatter, you're going to lose some of your brainstem reflexes. And pathologists also saw something new that they hadn't seen before. They called respirator brain because these patients were on a respirator for lack of any other term, and found that the brain was crumbling apart. There were pieces into the spinal cord, pieces of the cerebellum were in the spinal cord. That suggested that there was a large part of the brain was starting to become necrotic from no vascular supply to the brain. But we had to wait till 1959 when a neurosurgeon, Wertheimer, published a paper and said that he could find criteria for brain death. And what he did is that he would make small burr holes, put in a needle into the brain, and then stimulate as deep as the thalamus there, where the TH and T1 is the thalamus on both sides. And if there would be no motor response, he would declare the patient brain dead. I'm very glad that it hasn't caught on. And then at the same year, two neurologists, Mollaret and Goulon, published a paper called Le Coma Dépassé, which has been translated multiple times. And what it basically means is irreversible coma. What they meant is that, and here you can see it, there was much of it is known as what we now use to do our brain death examination. There's some interesting observations here, such as jaw droop, but the important thing here is that the blood pressure was dropping progressively. And what they did is that they said, this is a new coma, and we can categorize it beyond the other comas that we know. And you can see that the big difference is that these patients are not breathing, and their blood pressure is sinking in and needs support. And then nothing happens. For about 10 years, nobody was interested in brain death until 1968, a very tumultuous year in the United States, in which Henry Beecher, an anesthesiologist, got together a group of experts to define brain death. And he said, classically, we should first abandon the ancient sign of death, the cessation of heartbeat. And he got together a group of specialists, and these were 3 meetings. As you can see, these are the logs of the meetings. You can see people don't go to committee meetings. And they talked for 3 days and wrote down a manuscript that was largely written by 2 neurologists, Adams and Schwab, who wrote the major part of what became known as the Harvard criteria. As you will see, when we progress into the understanding of brain death criteria, this is a simplicity that we all would like to aspire to. Unreceptivity and unresponsivity. Adams is very concerned about a locked-in syndrome and would want to exclude that. No movement or breathing, no brain stem reflexes, a flat EEG, repeat the examination for 24 hours, and then make sure there are no other confounders. That includes hypothermia or any other central nervous system depressants. Published in a JAMA, who decided to put an image of Black Death on the cover, published it as the definition of irreversible coma, but also as a definition of brain death. 2 terms here that have confused a few people when this was eventually was published. And it made the New York Times, the front page of the New York Times, without any response, probably likely because it was just a few months before the elections and other things were more important than definition of death at that time. Now you may say, what a committee says is not important, we should do a study, and that's of course important. So the NIH decided to do a prospective study. The only prospective study on brain death was done by the NIH in the 70s. And they decided, let's take all these comatose patients in multiple centers who have no brainstem reflexes and are apneic, and then see them on a continuous basis and see how they do. And they found a subgroup of patients who were not breathing and comatose at a flat EEG, and most of these patients, the overwhelming proportion of these patients, had a cardiac arrest within the first week or so after they were seen. 2 survived who had a drug intoxication. This study suggested and made very clear that the heart stops after the patient has been brain dead. And the reason for that is complex, most likely because there is a collapse of the vascular tone as a result of autonomic uncoupling that will lead to the baroreceptors not really to respond to it, invariant heart rate that would lead to decreased contractility and eventually to terminal cardiac arrhythmias and terminal arrest. The US collaborative study was problematic, though, and did not do apnea testing because they quoted it was judged impractical to do that. There was some concern about doing the apnea test, a concern that still is there today, in which 1/3 of the patients were basically in shock when they were examined. There were intoxications. And there was also a big problem with testing of these patients. You look at these numbers here. These are patients who have their reflexes untested. And you can see that everybody tests the pupils and everybody tests corneals, but when you go down in the brainstem, a lot of reflexes were not tested. I call this the rostrocaudal deterioration of your neurologic examination. This group came together and organized a large symposium that discussed brain death. that eventually led to the Brainstem Commission that have these criteria that you can all recognize. They introduced apnea testing using a PCO2 target, introduced cerebral blood flow testing as sort of an additional ancillary test, but in fact the major principles remained the same. Published in this book, Defining Death, that led in the United States to a law that said you can be dead when the brain is dead. And this has been parsed by many ethicists and read over multiple times, but it says the following: irreversible cessation of all functions of the entire brain, including the brainstem. And including the brainstem was mentioned here because nobody wanted to have a higher brain definition of brain death, and therefore the brainstem was introduced, is dead. Patient who has irreversible cessation of all function of the entire brain is dead, but it is the doctor who decides what he means by death. And that was an important finding. So the UDDA is not a standard. The standard is really really your neurologic examination. And then several years later in Minnesota, there were two neurosurgeons who said, well, it's maybe not the brain that is all that important, it's the brainstem. That really is the moment that you die. Found patients who had EEGs that still showed some activity, but the patients were clinically brain dead. And that was taken over by the British, who, and it is always considered a British approach to brain death, but it really came from the US, that the brainstem is really the final defining moment when someone has loss of all brain function. So the idea has been always that in evolution, we started as a brainstem, and then we put our thinking parts on top of it. We started, as you can see here, as a fish, and then eventually became a human, where all the thinking parts came upon the brainstem. The brainstem is truly where we need to look at, and is what we look at when we define brain death. So you have a supratentorial lesion that eventually leads to an infratentorial catastrophe. Anything what happens here, whether it's a mass or the diffuse edema, eventually will result in loss of all brainstem function, usually in a rostrocaudal fashion, starting with the mesencephalon pons and medulla resulting in apnea. And so the brainstem remains a crucial part in the determination of brain death. Now, apart from that, the important observation, the American Academy identified several areas of need, as you can list it here, and this led to an important guideline that looked at the number of assessments you need to do to declare brain death. I don't want you to read this, but it basically shows that it is 25 assessments necessary to declare brain death. A lot of patients, a lot of time is necessary to make absolutely sure that there's a good examination of the prerequisites, that the patient is not hypothermic, has no sedative drug on board before an examination is started. The children in the US also led to a guideline, an important guideline, and that was recently published in 2011. There's some very good things to say about the US pediatric guidelines. As you can see here, they de-emphasize confirmatory test, and they have an important appendices on the medication checklist. But what is not so good is that there are age brackets for uncertain reasons. The confounded evaluation often comes after the examination. Ancillary tests are possible if there's medication. And then, again, 2 physicians, 2 apnea tests with a 12 and 24-hour wait. And not all physicians are allowed to do a pediatric brain death examination. So you can argue and have a hypothetical case of a car accident with 3 teenagers who then are declared brain dead, that the first one would wait for a second examination, get a cardiac arrest, and would not have organ donation. The third one would wait for a second examination. The family is devastated, don't want to deal with it anymore, and refuses DCD, and there's no organ donation. But the adult teenager here at 18 years old follows the American Academy adult guidelines, has 1 examination in which donation follows. It is not a terribly hypothetical case, but it tells you how strange it is that we would have different guidelines in younger kids, while at the moment you get 18, this would change. So there are controversies, and I won't get to this in more detail. There are some who do not accept brain death. In fact, there are some who do not accept any death. So, and that's been known for many years. I mean, there's been for many years that there have been books on the uncertainty of signs of death. And in fact, when I looked at some of the charts, I found that sometimes physicians find it difficult to know when someone is dead. Some of the writing here shows 3 times of death in this patient who was declared brain death. So we'll have to define a little bit what we mean by that. And there are several physicians, mostly physicians that are against brain death, and some of these criteria that they used are of interest to read. The apnea test considered to be dangerous. Schumann, a pediatric neurologist, feels that the body may remain alive without brain function, and there's no cardiac arrest in several cases, which might be true, but that doesn't necessarily cause a problem with the definition of brain death. And a pediatric intensivist from Canada feels that recovery of brain function has been reported, although the argument has been, yes, it has been considered to be associated with confounders, but how do you know it's confounders, that perhaps they do recover? So there are concerns by some physicians who feel that there's an argument against it. And then this paper in the New England Journal feels that basically makes the argument that physicians do not know when someone is dead, so let's just forget about being absolutely certain when someone is dead and get rid of the dead donor rule. The President Council of Bioethics considered all these concerns and eventually came to a conclusion that brain death is not a major controversy and should be considered the death of the person. But it hasn't stopped right there, because last month Robert Vetch published this very interesting book, who says that the definition of death is not a scientific question, but a social one, and individuals and families should be given a choice. So it's not a medical decision, it's a decision made by families who can decide whether they consider a patient dead or not. To me, the real issues are these issues. The issue is expertise and competency, uniformity, and what do we do with the ancillary test? How can we define physician competence? And are all specialties really allowed to determine brain death? Or should we say some specialties should not be allowed to do brain death? The American Academy has never ever said that anybody should not do brain death examination if he's competent to do so. And we do have opportunities to look at how physicians perform when they do brain death examination. We recently tested that, and in a scenario, in a simulation scenario, in which we found that many physicians had big trouble with understanding confounders before they do a brain death examination. But they can be trained and will be able to remediate when they are retested in their simulation program. Do we need 1 or 2 examinations? In the US, about 8 states have decided that 2 examinations are necessary. Are there independent examinations? Some have told me, well, why don't you only have to do 1 apnea test. That's sufficient. You don't have to do 2 apnea tests. And 2 examinations can lead to marked delay and loss of donors. This was a study in New York in which there were 6 hours in between 2 examinations. And this shows you, every bar shows you one hospital. The lowest bar is 6 hours. All the other bars are more than 6 hours. On average, 3 times more than necessary. And there was a 12% loss of organ donors due to cardiac arrest by a simple hospital requirement to go to a second examination for 6 hours. It doesn't work in practice. And then ancillary tests. Ray Adams said when he wrote the Harvard criteria, the final judgment must be made on clinical grounds. The physician who would permit such a crucial decision to be made by a machine, ingenious as it might be, leaves himself and the patient in a highly vulnerable position. Because ancillary tests are difficult. This looks very much like an EKG, but it is an EEG in which we should see that there is no activity. A nuclear scan is notoriously difficult to interpret. Most of the mistakes that I've seen, most of the pitfalls that I've seen, are with interpretation of the nuclear scan. Is there flow or is there no flow? A transcranial Doppler is dependent on an increased intracranial pressure. If there's a large increased intracranial pressure, if it's high, there will be reverberating flow, as you can see here. But in other situations, the transcranial Doppler is not so important. And then CTA, which has been used more often. Yes, it is interesting if you don't see a carotid or a vertebral artery entering the brain, but in many situations that's not necessarily the case. As you can see here in a patient who was declared brain dead, and someone did a CTA, you can see there is intracranial flow, although most of the flow is in the extracranial circulation. What do you do with these studies? Is this a positive study or a negative study? And if your tests are incomplete and you use a flow study and then you do an EEG and your EEG shows no activity, what do you want to do? What do you want to use, the flow study or EEG? You can imagine how difficult that is if you use these ancillary tests if they're not congruent. There is also variability in the brain death determination, and we looked at that many years ago. These are hospitals who make different policies and changed the guidelines that were instituted, and found that not everybody uses exactly the guidelines. That's not surprising, but it shows that in many important parts, such as the confounding factors, guidelines, hospital guidelines do not necessarily use any of these prerequisites. So recently we looked at if the new guidelines that were published by the American Academy of Neurology, and see if the top hospitals that we used as the US News World Report, top 50 ranked hospitals, you can argue whether those are the best hospitals, but those are the hospitals that we looked at, and looked at their policies on brain death, and found that if you compare it of 2006 and 2015, you can see there is some improvement in assessment, but it is not 100%. There's still hospital policies that are not really up to snuff towards the American Academy of Neurology guidelines, which is the most conservative and most vetted guideline that there is currently in the United States. And then how about the rest of the world? The rest of the world there's a lot of variability in the rest of the world, as you can imagine. And most of the variability has everything to do with ancillary testing. Here you can see what the differences are. Many of these countries have optional ancillary tests or are not using it, and the number of mandatory tests in countries have declined substantially. As you can see here in these yellow bars, it's only a small proportion. But why some countries says it's optional, another country says it's mandatory, another doesn't even use it, remains a big mystery and is not resolved. So how can we come to those uniform criteria? And I think, although everybody likes to look above the tentorium and likes to look at the big brain, it is far more important to look below the tentorium and to look at the brainstem, because we know there is a clearly clinical dividing line. If all brainstem reflexes are lost in a patient's apneic, nothing returns. Not a medical intervention, not a surgical intervention, not a divine intervention. When some is preserved, however, if a brainstem is preserved, brainstem reflex preserved, you can recover. Neurosurgeons know that. If they take out a cerebellar hematoma, the patient can improve. If they drop in a ventriculostomy, the patient can dramatically improve. But if all brainstem reflexes are lost in apneic, it's a dividing line. It's an important classic neurocritical care observation. So stick to the bare essentials. Use cause and confounders. Go to a neurologic examination and apnea test. That will be one possibility to come to a uniform declaration of brain death. Because it can be so simple. An unsurvivable brain injury, you define that there's nothing more to do to that patient. You eliminate any confounders. You test brainstem reflexes and motor responses. You do an apnea test and find that the patient is not breathing. You note the time of death, and you could declare the patient brain death. It's that simple, if you stick to that simple principle. Brain death is declining. It's not only declining in the US, it's also declining in Canada. As you can see here, it's dropping dramatically. It's also declining in other countries. This is from Holland, in which the number of patients that are declared brain dead. And why would that be? One of the reasons is there is reduced gun violence and gunshots to the head. You may find that hard to believe, but in New York, the number of brain death determination dramatically reduced when violence in New York was under better control. More decompressive craniectomies, perhaps, that the ICP is not able to rise that much because we are doing more decompressive craniectomies. But the biggest deal here is that it's more often early withdrawal, or physicians who simply do not consider that. In emergency departments in which there's withdrawal of support, in which patients are not admitted to the ICU, that potentially could be donors. I think much of that, much of the loss and decline in brain death determination has everything to do with early withdrawal and physicians simply who do not consider brain death. So we do have major responsibilities. We need to develop a rapport with family. We have to determine futility. We have to start initial management of an evolving hemodynamic instability. These patients are very unstable. They have diabetes insipidus. They're hypotensive. They need drugs to maintain that. Declare brain death and then discuss with organ donation agencies the organ, whether the patient is eligible for organ donation. And thus leave the organs here and don't let them go to heaven. Thank you very much.
So we have lots of time for questions. So please feel free to come up to the microphone. Dr. Wijdicks, thank you very much. I just would remind our Canadian audience that we have national guidelines here in Canada that were produced in 2003 and published in 2006 in CMAJ. Dr. Wijdicks was very helpful in those guidelines as well. Let me ask you a question because we've been down this road a little bit, and that is, when you say one of the major challenges is uniformity, I guess what you mean is consistency of best practices. And do you think that there can be achievement of a global consensus in brain death determination?
I personally think no, and that's maybe a depressing answer. It would probably be very difficult to change, to have almost every country in the world that is making that assessment to follow a single guideline or a single assessment. However, I do think that we can simplify it and that we can go back to simple criteria and not having all kinds of additional criteria that would make it very difficult to come to a conclusion. Certain countries have more criteria than other countries. I have not specifically singled out countries, but there are some countries who have an enormous amount of additional safeguards. I think that's what it probably is, safeguards to make sure that the determination is done well. So can we come to a uniformity that everyone does it the same thing? I think it is probably difficult to do, but I definitely think we could probably simplify it.
Please.
It's great to have had this talk from you. I'd like to ask you two specific questions. One is Greer's paper on CT angiography potentially showing no flow in a patient who is alive. I'd like to hear your thoughts on that scenario. And a second and different question is your thoughts on the patient with an isolated brainstem lesion. Dr. Shimi has a slide, for instance, of a pontine hemorrhage, a patient who's pronounced dead by neurological criteria, whether or not there's any possibility in your mind, based on anecdotes you've heard or cases you've seen, that that patient might subsequently, given time, recover brainstem findings.
So these are two important questions. First is, why do you have blood flow if someone is clinically dead? That was your first question. Well, that has to do with, simply has to do with your intracranial, the number of your intracranial pressure. So blood flow to the brain is a reflection of your intracranial pressure. If you have a very high intracranial pressure, blood flow doesn't go in. If you don't have all that high intracranial pressure, blood flow would still be going in there. So it has nothing to do with your examination, and therefore it is entirely separate from it. There's a lot more to be said about that. If you talk to angiographers, they can tell you that they always will be able to put in contrast into the brain, and they always will be able to do that. It depends on how you do what the technique is. If you let it flow in, contrast flow in, or push contrast through. So there are many technicalities that can make it a positive or a negative blood flow study. And that's, I think, is problematic. It's really a reflection of the technique. It's a reflection of the intracranial, the magnitude of the intracranial pressure. Now, the commonly asked question is primary brainstem death, is it possible to have, to recover from primary brainstem death? And is it possible that there might be someone in there in the brain while the brainstem is, when there's a primary brainstem lesion? I think someone should have to prove that's the case. I think the first observation is that primary brainstem death is extraordinarily uncommon. Pontine hemorrhages do not cause brain death. It's rarely the case. The same thing with infarctions and acute basal occlusion rarely causes brain death because the lower part of the brainstem is often preserved, and the lower part of the brainstem maintains blood pressure and maintains breathing. So it's a very uncommon feature. It does occur, however. I think if you would want to argue that there might be some activity in the brain or that someone could improve, that will have to be proven. Otherwise, it would immediately challenges the concept that loss of brainstem function in an apneic patient would not be correct, and that has not been challenged.
Hi, thank you very much for the talk. Whatever we decide, the discussion about whole brain death or brainstem death, I think it's more a medical discussion. But the fact is more a medical discussion for doctors. But I mean, whatever we decide as criteria, we have to convince the general population that this patient is dead. And as far as I'm concerned, brain dead is for organ donation. I've been practicing ICU critical care for about 11 years now, and I never did an examination of a brain dead examination in a patient that I didn't believe that could go on for organ donation, which means that I'm using the brain dead criteria in the diagnosis of brain dead for organ donation mainly. Now my point is, would it be better for the general population to make them understand brain death if we doctors starting to do more brain death examination on patient before we disconnect them from the breathing machine, or telling the population that this patient is dead, and make them believe that brain dead is actually a clinical situation, is a diagnosis, then will help for the organ donation after and the acceptance of brain death.
So your question is?
My question is that we have a difficulty for the population to believe in the brain death when we say the family, this patient is dead. Because of our criteria.
You're arguing is that
should we make this diagnosis more often and use those criteria more often for population?
It's a public policy question, and families have difficulty grasping the concept of brain death. I'm not entirely sure if that's the case, really. I think in my own experience and experience of organ donation agencies, the overwhelming proportion of families know exactly what is ongoing. Now, if you have a patient that comes in and comes in brain death into your intensive care unit, and you suddenly have a grieving family that out of the blue is confronted with someone who has lost all brain function, then I can imagine that it would take a little time, or to take actually a considerable amount of time, to come to some sort of rapport and explaining what is happening. But in my own experience, when patients are declared brain dead, They come in with a catastrophic neurologic injury. We know nothing else can be done. The patient's on a ventilator. We try to support the patient as best as we can. And then within the next 24 hours, we have multiple conversations with family members about this is what is going to happen and this is what we're going to do. And in general, I think with multiple conversations with family members, I think the understanding is good, and we can get a good rapport, and they would understand that the patient is not here anymore. In fact, in my own discussions, I often hear family members say, when I say, I'm going to do a brain death examination, they say, I expected that you would want to do that because I knew that something happened overnight. And I think they noticed that the blood pressure dropped, or their patient was not triggering the ventilator anymore, or something really happened in which they noted that the patient was gone, it was not there anymore. So my personal experience is that I think a lot of family members have a very good understanding, and there might be a disconnect between what is done in surveys, what kind of questions are asked, and what we see in clinical practice.
I suppose in almost every single case where you would perform a brain death examination, you would want to be considering that patient as a donor. So it's not as if you have a very large denominator. Well, could we have a steady stream of a low frequency, but a sort of steady stream of families who simply don't accept brain death, and there are various strategies to sort of overcome those difficult few days until, you know, the ventilator is withdrawn. What's your approach in that situation?
Our approach is continuous communication, and it's usually it's not necessarily religious. I think in my experience, it's more a cultural issue, and so different cultures have different approaches to it, and so our approach has always been to to have multiple conversations and continue support while having multiple conversations. And in a large proportion, we're able to come to a conclusion. The issue is also that often these patients are unstable and would get in a cardiac arrest. Building a rapport with family members and have them understand that your interest is their interest, I think is most important, really.
Thank you. Just give your name and where you're from, please.
Steve Bede from Halifax. We have a clinical scenario that is the most difficult one for our teams to deal with, is the presence of spinal reflexes and how that complicates the assessment. We're doing an assessment for a deep coma, but also full assessment of brainstem function. But when spinal reflexes are present, which they are fairly frequently, we end up with families and or medical staff who are pretty uncomfortable concluding that this patient meets criteria, and then we get into the conversation around the need for ancillary testing. What are your thoughts on that?
Well, I have a talk on that. That's coming later. On
Okay.
On spinal cord reflexes.
Don't spoil it.
Okay.
So I can. What is my answer to it? Is I think we have to document it. Our personal experience with the spinal cord reflexes is that if they are not documented and nobody knows about it, then it has, in our experience, at least I have experience of 3 situations in which the surgeon didn't want to take out the organs when there was a spinal cord reflex, not aware of it, and the nursing staff was not aware of it, and the patient went back to the ICU, and then you got trouble, and you have to a lot of explaining has to be done until you can go back to the intensive care unit. So yes, it can happen, but I think again by documenting it and have a good handoff of what is happening to that patient. I think spinal cord reflexes are not as common as we think they are. They're probably more common in children, and some of them are, and you can categorize them as simple triple flexion responses, which they mostly are. And if they are explained, I see no difficulties with it.